Still want to call it. Oh, I'm sorry. Ben Stefan, Executive Director of the Mental Health Care Commission. I do believe I recognize the.
We work with each other and on my phone.
So our responsibilities are health planning, promotion of health information technology, the development of an all-payer claims database, and quality reporting efforts. We work closely with the exchange both formally in this capacity, but also at the staff to staff level. And it's a very effective collaboration. I'm happy to say, and hopeful we shall agree.
I got everyone.
I'm Cynthia Wilson. I'm Michelle's assistant. I actually was working for Josh when you came on
Oh.
board. I know you did too, but, I've been with the state for 40 years this year, and I've actually worked for 4 cabinet secretaries at the health department. So I don't think I was there when you.
None
were
of them
there.
women, I'm sure.
No, they weren't. So but I'm happy to have you on board.
Thank you.
Of course, we've met.
Yes.
Yes. Oh, Tony McCann. I've been on the board for 8 years. I teach at the University of Maryland and had some involvement with the state prior, and now back in the Jurassic period. Without further ado, let's move on. The first, you've all had a copy of the minutes. Do I see anyone who needs changes, revisions, anything else? Then I'll entertain a motion to approve the minutes. Mary Jean, any further comments? Second, any further comments? All in favor, say aye. Aye. Opposed? The ayes have it. I have a statement to make with respect to the disclosure of a closed meeting. The board met in closed session on January 17th, 2023 to discuss an MHBE personnel matter that affected one or more specific people. The following board members attended the closed session: Dennis Schrader, Chair; Tony McCann, Co-Chair; Diana Wessaker, Kathleen Baran, Ben Stefan, Mary Jean Heron, Singh Taneja, and Maria Pilar Rodriguez. The following board staff members were also in attendance: Sharon Merriweather, Principal Counsel, Michelle Eberly, Executive Director, Andrew Ratner, Chief of Staff, Giselle Stamp, the Director of HR, and Cynthia Wilson, Executive Assistant. After discussion, the board determined that no action was needed. The next item was public comments, and we still have no one has asked for public comment.
Correct.
Executive update, Michelle.
Well, thank you very much. And first, I'd like to start by welcoming Secretary Herrera Scott, and really just thrilled that this is our new board, likely our new board chair. I think that has to be appointed by the governor, but just coming on to the board and her experience with the exchange when we first started way back when. And I think I told the secretary that when I was hired at MHIP, she and Josh Sharfstein were the ones that came in and talked to me. So a long time ago. We had planned to all go over to Lourdes afterwards today for a little celebration, although Secretary Herrera Scott needs to go meet with someone at the request of Senator Cardin. So for all the rest of us, we can still have a little time, a little board staff time if you're able to do that. Just to update on some of the things that have been going on, easy enrollment kickoff event. We had a really wonderful kickoff to open enrollment for tax season. Controller Learman hosted us at the controller's office, and we had the original bill sponsor. Senator Feldman was there. Senator Van Hollen was there. He came as promoting the same day that he was refiling this bill to have it be a national endeavor. So that was really exciting. Our new Lieutenant Governor, Aruna Miller, was there, and that was fun. It was just a really nice kickoff. And again, many thanks to Healthcare for All and Vinnie DeMarco, who's our #1 cheerleader and really makes sure that healthcare stays at the forefront for everyone in Maryland. And just as a reminder, as we start to kick off this 4th tax year easy enrollment, we've enrolled over 10,000 people through that program in the first 3 years. So it's been very successful. The public health emergency unwinding, this is, of course, first and foremost on everyone's mind. We've been working very closely weekly with the Maryland Department of Health to make sure that it's a smooth transition for those that are rolling off of Medicaid. We've, of course, as we have all the enrollees, Magi enrollees in our system, we're providing data in terms of who is no longer eligible for financial reasons, for aging out over the age limit, et cetera. There will be a phased termination of folks depending on their situations over the first 4 months. Will be based on categories. Again, if we know that they have aged out for income, if we know they've aged out over 65, and then Maryland is going to take the full year to roll folks off as they redetermine. Just remind you that in Maryland, we're unique in that we can
First up, we have the Chick-fil-A gift card
every month over the entire public health emergency period. What that means is we did not terminate anyone, but we were able to at least reach out and say, if you've changed, if you have different income, different situation, come on back and let us know. You're going to get a full presentation in April on this, but just as a heads up, the managed care organizations are working with the Department of Health to do campaigns, outreach campaigns. There will be social media. There will be some TV media spots. And in fact, I've already started to see one being aired, I think, by Maryland Physician Care is out there again, encouraging people to come back and update their information. We are also working with our call center vendor, Maximus, providing them with the details of when we expect these increases will occur for people being terminated, and looking at their contractual scope of work and looking at what additional needs there might be to provide support for these folks rolling off. Some of the things the exchange is doing proactively to manage this is we've been working with CMS to be able to get Equifax data when we ping the hub. And that means that in addition to the IRS data, which is year-old data, with our Department of Labor data, which is quarterly data, we'll be able to get, for most people, we're still testing out how many that will be, but up to current payroll information. So again, on Medicaid, they really look at the current income as opposed to on the QHP side, we look at what we anticipate to make for the year. We're also looking at an easy enrollment process for those terming out of Medicaid that would be otherwise eligible for QHP. So we could easily enroll them right into a QHP. And then some of the behind the scenes work, we have robotic process automation that we're putting in play for verification of income stubs. So we've done that on the QHP side for over a year now, and implementing that soon on the Medicaid side. Again, what that means is removing barriers for people to get coverage. So instead of something kicking out of the system, having to go to a person to look at and verify, get in a queue and wait to be worked, we could do it through the robotic process automation. So those are some of the updates on public health unwinding. Again, I think Maryland as a whole, I'm very impressed with the collaboration ongoing to make this a really successful effort. The legislative session and hearings, both of our budget hearings have been completed. Last Friday was our Senate hearing and yesterday was our House hearing. We also have met with the Department of Budget and Management to talk about our budget. As you'll recall, it was reduced from 35 million down to 32 million. We did put in a deficiency for this fiscal year for the call center and for fulfillment. It's likely we'll get general funds for that. And then moving on for fiscal year 24, again, we will likely start to get general funds to support the needs that we have. So more to come on that. In terms of legislation, Johanna and her team have been quite busy looking at all the bills that come in and doing fiscal notes and preparing testimony. Some of the things that are coming down the pike that impact us, qualified resident enrollment program, that's the access to care for all Maryland citizens, whether you have documentation or not. And that is going forward with Senator Lamb and Delegate Cullison, who are sponsoring that. There's two components of it. One is to allow the exchange to file an amendment to our 1332 waiver, wherein consumers could enroll through the exchange. They would obviously not be eligible for federal tax credits, but they would be eligible for any state funded only funds, programs that are available, like the Young Adult Subsidy Program, which is available. There also is the special enrollment period of marketing for small employers. This again came out of the work group that Johanna and her team did last summer, which was, so successful, where we are looking at whether or not legislatively we're mandated to look at whether or not to provide a subsidy for small businesses. And that work group had insurance producers, third-party administrators, nonprofits, the chamber, small businesses. And at the end of that work group over the summer, collectively, they all agreed that this was not the time to put in a state subsidy for small business when the subsidy programs, the tax credits for individual market were so robust. And so to instead make sure that the exchange had funding to do outreach for small businesses. So that's moving forward on that bill. Let's see, a couple others, the Young Adult Subsidy Program, a continuation of the pilot program. So that's coming up this week, and that has been a successful program. And I think there'll be good support all around for that. I think that's it. There was one bill that was filed in the House and the Senate that ultimately got pulled. It was called Professional Employer Organization, and it was allowing professional employer organizations the ability to offer a health insurance product, which is very similar to association health plans. So that was filed. They both have been withdrawn, so that's good. It's I think we are viewing that as another association health plan. So with that, I will stop. That was a lot for today and answer any questions if you have any.
Questions for Michelle? Yes.
A question on the qualified resident program. Did the exchange take a position of support with amendment? What was it?
We did do a letter of support. However, we're agnostic on the subsidy for it. So that was a two parts. I don't think I mentioned the second part. The first part was being able to apply through the exchange. The second part was subsidy funding to provide, in essence, the federal tax credit, which will be a larger amount. And from the exchange standpoint, we can get folks enrolled whether there's subsidy or money or not, and would like that not to dissuade that bill from passing.
Of course, if there's no subsidy, it's very unlikely the uptake would be significant. I would think.
It would likely be minimal, but again, any state subsidy programs that are in place today or in the future would be made available.
Thanks. Other questions? We stopped for a moment. Maria, we went around in the beginning before you arrived and introduced ourselves to the new secretary. So let me turn the floor over to you with who we are and what we do when we're not on the board.
Hi, sorry for being late. I got a little turned around there. My name is Maria Pilar Rodriguez, and I kind of new to the board, so I'm still running through the waters, if you will. And when I'm not doing this, I'm smoking zone, and also executive director for the Maryland Hispanic Chamber of Commerce.
Great.
So working with a lot of different community groups and stuff. And a grandmother 3 seasons before my parents.
And we're gonna have the grandparents caucus. As you know, we have a policy committee. Dr. Allen is the chair, I believe, as a chair of the policy committee. And Dr. Allen, you have a board report.
Good afternoon. So the policy committee met on 2 occasions, January 23rd and also February 6th. So I'll discuss the summary from the meeting on the 23rd. So in preparation for the public health emergency unwinding and in consultation with the Maryland Department of Health, the staff proposed emergency regulations to easily enroll individuals no longer eligible for Medicaid coverage into a qualified health plan. And of course, this will be on today's agenda, and I think Michelle is kind of getting this already. The policy committee also continued discussion on appeals from producer authorization termination and unanimously agreed to recommend the board designated responsibility for these hearings to OAH, which is the Office of Administration Hearings, and this will also be an agenda item today. So that was something that we pretty much discussed from the meeting on the 23rd. On the February 6th, the policy committee discussed the current board member onboarding orientation and suggestions, any changes or opportunities for additional engagement with members. After that discussion, we noted that the new member orientation that's currently being provided has been meaningful. It would be beneficial to add a mentor or buddy program where each new member is assigned a current board member who helps with the onboarding. And that also would also be beneficial for new members to meet the board chair and vice chair department orientation. And I believe the staff is working diligently to implement some of these suggestions. They're all now assigned. Then lastly, the staff proposed establishing a quarterly speaker series to bring in experts in policy areas relevant to the exchange. These would include state strategies to expand coverage options for undocumented residents, how waivers are moving to a second generation and becoming more refined, and how to capitalize on 1332 and 1115 waivers and ways to cover those rolling. That concludes.
Thank you, Doctor. Are there any questions for Dr. Allen? Thank you. As all of you know, one of the most important boards that supports us is the Standing Advisory Committee, and from time to time we make appointments of new members, or new members are appointed. Mr. Frank, you'll come up and talk to us about the new members.
Thank you. Thank you all for having me today. My name is John Frank. And I've been a member of the Standing Advisory Committee since 2001, and I'm currently the co-chairman of the committee. And as you may be aware of, our committee is a rotating committee. So we have about 20 members and 3-year terms. So every year we have to replace 5 to 7 members who time off of our committee. And I'm here today, replacing, or not replacing certainly, but standing in for, thank you. Standing in for Dana Wexler, who is a board member, and she asked me to come and deliver our report this morning to you, this afternoon to you. So we have 5 members that have completed their term and 2 members who departed due to resignation, and we were able to bid them farewell at our last meeting. And that group included Ken Brannon, who many of you have had the pleasure of meeting before. He was the co-chairman, so with his departure, that left the responsibilities to me. And in addition to new members, we're also going to be looking for an additional co-chairman for our committees. As usual, if you can kind of flip to the first slide. As usual, the MHBE staff did an outstanding job of managing the process for us. They posted on the website, shared the knowledge that we had some openings with members of the committee, as well as just in general nature to find some new members for us. And we were very successful this year in finding a great group of new members to come in. This is not, in using kind of a sports analogy, championship teams are not known to replace people, they're known to reload. And I think we've come up with members this year that certainly reload and improve some of the perspectives for our committee. We had 7 applicants submitted for proposal. You can go to the next slide, please. Which include 2 academic researchers, a Chamber of Commerce executive, several healthcare providers, and community nonprofit and community advocates. And the applicant summaries have been distributed, and hopefully you'll have a chance to look at the breadth of experience and responsibility that we're adding to our committee. We are still looking for a member to join our Standing Advisory Committee from Western Maryland, so that we can add the geographic diversity to our group as well. We did lose a member from our committee that was one of the navigator programs out there in Western Maryland, and we're seeking to make sure that we get that representation as well. So we bring forward a recommendation of these members to join the Standing Advisory Committee, and I believe that requires an action by the board to appoint them. And with that, I'll leave it open to comments and questions.
Does anyone have any questions for Frank? If we're ready to vote, then I move to approve the appointments of the applicants to the 2023 Standing Advisory Committee as presented, and they are listed on the slide above. Okay. Check with the boss. Do I hear a second? Second. Are there any further questions or comments? All in favor, say aye. Aye. Opposed? The ayes have it. Thank you, sir.
Thank you very much.
You're opposed. That's
Sure.
I think we're gonna, yeah,
Oh.
just leave it.
Oh, okay. Oh,
That'll work. Right.
you know, you said, well, you don't even need it. Go ahead, please.
Well, for those of you who don't know me as well, I'm Johanna Fabian, Arts Director of Policy and Plan Management at the Exchange, and I'm looking forward to presenting on the first of two regulations that we're bringing forward to the board today. Cynthia, if you're able to pull up the slide for the Medicaid transitions, and then you guys
Right there.
But I'll just start to say that we are, I think that's probably the last slide. For this part. So just as some background, as Michelle mentioned, Medicaid terminations are resuming this spring. They were suspended during a public health emergency. But they're starting up again, and the first notices will be going out to folks in April for coverage, for last year's coverage on May 31st, and then continuing on a rolling basis for the year. So with that in mind, we have been thinking and working with MBH to think about how we could ease the process of transitioning to qualified health plan coverage. So private plans for individuals who are no longer eligible for Medicaid, generally because their income increased since they first enrolled. And so now they're over income for Medicaid, but could qualify to enroll in a qualified health plan. And we looked with interest at programs that a couple of other states were standing up over the last year or so. California and Rhode Island both took action to put in place programs that would default someone who's leaving Medicaid into a qualified health plan. And there's some variations. We ended up feeling like we aligned a little bit better with what California is doing. So we talked to them a bunch and are proposing a process that is in many cases similar to what California is putting in place as well to simplify this coverage transition while still allowing people kind of the choice and ability to opt out of what we're proposing for them. So we are looking at two specific eligible populations, and this gets a little bit into the weeds, but I want to be clear about who is and is not potentially going to experience this process. So one group would be Medicaid enrollees who are determined QHP eligible during this kind of redetermination process that's going to be happening on a rolling basis over the first year. So they come to the exchange, they update their information during their renewal period, and our system determines, okay, based on this updated information, you're no longer Medicaid eligible, you're eligible for a private plan, but then they don't select the plan within a certain period of time, and we're looking about 7 days. So if they take no action, we would then default them into a plan, and I'll get more into the logistics of the process, but that's the first group, people who are determined eligible for a private plan, but then don't take the next step to enroll themselves. The second group would be Medicaid enrollees who reported that their income increased during the pandemic. So based on that income, it looks like they're no longer eligible for Medicaid, but we don't know that for sure because it could be some time since they reported that income, and their income could have varied since then. So those individuals will still have the full kind of redetermination renewal opportunity to come in, update their information, and retain their Medicaid eligibility. If they don't do that, and we are able to electronically verify within a narrow threshold their most recent income that we have in the system, and based on that attested income and our electronic verification, we determine that they're eligible for a private plan. If their Medicaid terminates because they didn't come back to the system to take action, this is the second group that we would default into a private. And then, so those two groups that I just described are on the slide. If we go on to the next slide, this is a high level process flow for what those individuals would experience. And I have a process for each of the two populations I mentioned, but they're generally similar. So basically the person doesn't take action in one regard or another. We determine them eligible for a private plan. They get terminated from Medicaid with the appropriate notices related to that. We then, upon, their termination, enroll them in a qualified health plan, and we'll make that decision according to a hierarchy that I will walk through. And then the individual would have the opportunity to not take up that coverage. They have to take action to activate the coverage. So although we will be enrolling them, that isn't a final step in the process. They have to either pay their first month's premium to actually activate coverage, or for a small portion of individuals who are eligible for a $0 plan, so we don't have a premium to pay, they would have to come back to Maryland Health Connection to affirmatively offer the coverage. So in either scenario, the person is having to take some step that indicates confirmation that they want this coverage. Yes, we will. And how are you communicating that? So they will get information in their termination notice for Medicaid explaining that this is what's happening. If they're in the group of people who come back into the system, get the qualified health plan eligibility determination, and then don't take action. At the point they get that determination, we will show them on the screen information saying, if you don't take action by X date, we will default you into this plan unless you want it. I'll just clarify my question. So are you communicating by mail? Are you communicating electronically? Because the Medicaid population can be transient in terms of housing. Yes. So I'm just a little concerned that people move, they don't update their housing, and then lose coverage because they mail that to an address that could have been sent out since he came here. Yes, so we will be communicating by mail, also email, and then we're looking at if we can also do a outbound phone call by our navigators. So multiple modes of communication, and also as part of the whole Medicaid redetermination process, it's a federal requirement that individuals get contacted by at least we attempt contact by 2 methods of communication in addition to mail. So we're looking at mail, email, and then a phone call or text. But that's definitely an important process because we don't want people to be confused, and that's certainly a risk of this process. So I think that about wraps up the process flow. So the individual will then opt into coverage either by paying their bill or selecting coverage through the Maryland Healthcare portal. If they don't want the coverage that we're defaulting them into, they cannot pay the bill or not opt in, and there will be no adverse consequences for them. They can also change the plan that we've selected for them. So they're not stuck with what we're doing, but we're trying to make it as simple as possible. So if they want to take the lease action to activate coverage, they can still do it with a fairly minimal set of actions. And what is the default plan? That is the next, let's go on to the next slide there. If you can move forward, Cynthia. One more. Okay, yes. So this is the proposed hierarchy. This is what we have put in place as our proposal for how we would choose which plan to put folks in. First, we'd look at if they have other household members enrolled in a private plan through Maryland Health Connection. If yes, we'll just put them in the plan with their family members. If not, we'll then branch off depending on their income, their federal poverty level. And this happens because if you're below 200% of the federal poverty level, you're eligible for special financial assistance if you enroll in a silver plan. So it's particularly advantageous to make sure you get enrolled in a silver plan. So that's the reason for the split there. On the left-hand side, so if you're under 200% of the federal poverty level, and this is similar kind of on either side, we'll check if your managed care, Medicaid managed care organization has a counterpart in the private market in Maryland Health Connection. So essentially, if you're enrolled with an NCO that's Kaiser, United, or Care First, they also have a private entity. We'll keep you with that parent company, and then we'll put you in the lowest cost silver plan that parent company has available to you. If you're not with one of those 3 carriers that's in the Medicaid market and the private market, we will just put you into the lowest cost silver plan in your region. And that will essentially be Kaiser in Kaiser's service area, through the center of the state, and then United also in that service area. And that could change though next year. That's just what it is this year. If you're over 200% of the federal poverty level, we'll do the same flow, or we'll keep you with your parent company if we can. But instead of putting you in the lowest cost silver plan, we'll put you in the lowest cost gold plan due to some quirks of how rates work. Gold plans are actually cheaper than silver plans for this population, and they offer better coverage. So it's kind of the best value option for them. So that's how the plan flow works. We did some very, I think the next slide has a timeline. We did talk to the carriers, and we sent this to our stakeholders to do a quick public comment process on this, and talk to MDH and the MIA as well, and sort of ultimately with all that feedback concluded that this was probably the best option, at least for now, when we're trying to stand this up in a short time. And in the future, we may refine this to take in other considerations into account. Next slide. So what we sent out to you was proposed regulations that essentially lay out what I just described. And what we're asking for is approval to submit these as emergency regulations. Normally I come to you to ask to submit just normal proposed regulations, which means you submit them, there's a 30-day public comment period, you consider those, make adjustments, come back to the board, ask you to vote to approve the final regulations, and then submit those. And so that can take several months. Because we are in a compressed timeline to try to stand this up before the Medicaid redeterminations kick off, we are asking to do emergency regulations. And so what that means is that, as you can see on the timeline here, we would be able to have them effective April 7th. They go into effect without that proposed public comment period process, but we do have to go through that process within 6 months. So we will then follow up by doing that process so that we can institute these on a permanent basis. But that's what allows us to get them up quickly. But as I noted, we did do a brief kind of informal public comment process with key stakeholders to get their input. And I think the next slide is a summary of public comments. I won't go through these in too much detail, but if anyone has questions, I'm happy to answer them. I think generally people, we got feedback that was supportive of the approach. As some comments that we take some additional factors into consideration, which I think we're not really able to do under the time frame we're operating under, but we will consider if we can modify going forward, and as we come back for the permanent regulations to the board, we'll be able to give those more consideration.
I do have a couple questions. In the timeline, you talk about, or you mentioned, public comment. This public comment already happened, so once we go through the emergency part, we won't be doing that again.
That's true. There will be public comment in the 6 months following period when we go through to finalize.
And then for the people that say, nope, I'm not going to do anything, we'll be tracking all of the decisions that were made, the ones we put in, the ones who changed, and the ones who said no coverage, so we know who has no coverage out there.
We will, and we don't necessarily know that they don't have coverage. They could have employer coverage.
Right, but at least through this process.
Yes.
And then last question, I'm assuming with the health plans, we're trying to keep them in the same payer because we're assuming the network is the same.
That's the big driving reason.
Okay.
Other questions, please.
Yeah, Joanna, how many people are we anticipating that this is actually going to impact?
So we estimate that there's about 100,000 individuals enrolled in Medicaid who have reported that their income exceeds the Medicaid threshold. As I said, that could be old information. So if they go through this redetermination process, they might come back and continue to be Medicaid eligible. That's probably the upper limit for over the next 12 months, but it's going to be something below that, I think.
Yeah, thank you, Johanna. I realize there's no right best solution for the auto enrollment issue, but in these communications, they are told that this is their auto enrolled, but they are free to change if they pay the premium and say, oh my God, I'm enrolled with You'll write health insurance. And I didn't want you'll write health insurance. So what do?
Well, they can always cancel the coverage, either by just simply stopping paying their premium or proactively contacting us to cancel. They would not have an opportunity to change plans after they've paid the premium unless they qualify for another special enrollment period.
Other questions? Yes.
And that would apply to people under a certain percent, but more than the special enrollment period, where is that track to?
Yes, so there are two special enrollment periods that are relevant to this population. There is one that we put in place last year pursuant to what the federal marketplace was doing. So anyone under 150% of the federal poverty level does have a year-round opportunity to enroll. So if someone doesn't loses their Medicaid coverage and they're under 150%, they can come in at any time. They're not bound by the normal 60-day window that someone has to enroll in coverage. In addition to that, the federal government announced that they're going to be doing kind of an all-purpose special enrollment opportunity for people who lose Medicaid coverage between now and next July during this transitional period. And that's regardless if you're, you don't have to be 150 below 150%. So we are also working to put in place that similar special enrollment period. So our system will know if you lost Medicaid, since we have a combined eligibility system. So if you come in to enroll at any point up through next July and you don't have coverage and we can tell you lost Medicaid, we'll give you an opportunity to enroll. So normally you just have 60 days after your triggering event, but really it's going to be a more liberal opportunity.
So somebody who's in that situation where they're like, oh geez, I don't want this after all, they do have a little extra time, but they can get another plan.
Yeah.
You guys have worked so hard on this. I know, my team, we talked about it, but really, MHBE is very involved in this. I think that there is absolutely no perfect design because people aren't perfect, but I think we really try to anticipate use to the best of the options that are out there. So I just want to say, really appreciate all the work and the outcome. I also will say that the MIE will come alongside you guys in any way that you think is productive for us to do advertising. But Joy Hatchett from our consumer education advocacy group is looking to put together information about how to use your health insurance once you have it. So we're happy to collaborate with you on that as well, but to the point of a population that may not be as conversant with how to use the commercial product versus the Medicaid product. That is, we plan to start rolling them out with webinars.
Wonderful.
Other questions? Just a quick one. You mentioned that you're also offering people the suggestion that they might go to a qualified health center, state health center. Do we normally do that when someone comes into our system who's uninsured, is looking, not Medicaid, for whatever reason, not able to sign up for a qualified health plan? We normally say to them, oh, by the way, there's another option.
We don't really want to give them thoughts that they would do something other than
I got
get
you.
coverage.
I got you.
They're going to want to get them insured.
Right,
Yeah.
right. Yeah, probably that's right. Yes,
So
yes.
the benefit of the extra
Yeah.
right suit.
Unless they, well, I got, I'm sure how they fall between the cracks.
Again,
Yeah,
or
yeah, you're right. Absolutely.
get them with private insurance because, they will
Yes, you're
get
right.
so much of a grant for insurance, so.
Last sort of question. Presumably there are going to be other states around us who don't do a very good job. And presumably we're going to have press calls saying, what terrible things are happening in Maryland. And I guess my suggestion is that we need to think about how to proactively deal with that, with the press and so on who normally we deal with to give them a mini of this thing so that they know what we're doing.
Yes, we've been talking to engage about that communication strategy.
Good, thank you. Then, if we're ready to proceed, I move to approve the adoption of the Medicaid Transition Easy Employment Emergency Regulations as presented and authorize MHBE to submit them to the Joint Committee on Administrative, Executive, and Legislative Review for emergency adoption as presented. Do I have a second?
Second.
Once again, Mary Jean, any further comments or questions? All in favor, say aye. Aye. Opposed? The ayes have it. Our next issue relates to some legal matters. Welcome.
Good afternoon, everyone. I'm Nicole Quigley, happily go by Nikki. I'm one of the assistant attorney generals under the guidance of principal counsel Sharon Merriweather. Today, we're discussing the possibility of making changes to chapter 10 of the exchange's COMAR provisions, which is the chapter on producer appeals, which has been proposed by the board's policy committee. The committee believes that the regulations regarding procedures for hearings by or through the board requires changes in order to be congruent with the relevant provisions of the Administrative Procedures Act. Since its inception, the exchange has had the authority to take action on a producer's authorization to sell insurance on the exchange. That action includes suspending, revoking, or refusing to renew a producer's authorization under certain circumstances. If the exchange does take one of these actions, the exchange must also provide the producer the opportunity to appeal the decision through a contested case hearing according to the Administrative Procedures Act. Next slide, please. Although the exchange has had this authority since its inception, the exchange has rarely had to exercise this authority. And when it has, it usually has been to revoke a producer whose authority has already been revoked by the Maryland Insurance Administration. If MIA revokes a producer's authorization, by default, they're also unable to sell insurance on the exchange. In these instances, since MIA is the agency taking action, any producer appeals are heard by MIA. Recently, the exchange has received and investigated grievances by exchange consumers regarding exchange producers. In these cases, since the exchange takes the lead to determine whether agency action is indicated, any producer appeals are determined by the exchange rather than MIA. Although it's anticipated that these actions on producer authorizations by the exchange will be exceedingly rare, it has prompted the need to address how the exchange handles appeals. The procedures and regulations as currently written impose a procedural burden which could slow down the resolution process. Next slide. The way the regulations are currently written, if the exchange takes action on a producer's authorization to sell insurance on the exchange, the board must decide whether the board will hear any requested appeals or whether the board will delegate to the appeal to OAH or whether the board will delegate to another party. Additionally, if the board delegates hearing authority, the board will need to decide whether the delegated authority will make proposed or final findings of fact, proposed or final conclusions of law, or proposed or final orders. And these decisions will need to be made on each occasion, which is why this process could impose a procedural burden, slowing down the resolution process. Next slide. Rather than the board making a decision on how the appeals will be handled each time this issue arises, the board policy committee reviewed the process and believes the board would prefer to have a standing decision in place for a more expeditious process. The board policy committee determined that the board would most likely prefer to delegate hearing authority to the Office of Administrative Hearings to determine final findings of fact, conclusions of law, as well as issue a proposed order, with the understanding that the board will issue a final order after review of OAH's findings. The board will be able to revoke this delegation at any time should the board wish to conduct any hearing in any particular case for any particular reason. Next slide. If the board agrees with the policy committee's recommendation and chooses to delegate hearing authority to OAH to issue a proposed order, the board will retain the ability to issue the final order. Under the Administrative Procedures Act, if the board doesn't preside over the hearing but issues the final order, the parties to the matter must be provided the right to file exceptions for the board's consideration. The exceptions are provided in writing and are limited to the parties' concerns with OAH's proposed order. In addition to the written exceptions, a party can also request to present oral arguments to a majority of the board before a final order is issued. Once any exceptions are received and any oral arguments requested or carried out, the board will issue the final order. Next. Based on the committee's recommendations, and should the board choose to accept the committee's recommendations, we've made corresponding proposed changes to the COMAR chapter that pertains to producer appeals hearings. We sent around a line-by-line item document which shows all of the proposed changes, as well as a summary of each of these changes by subchapter, so everyone could review them ahead of time. For the sake of time and to spare you the boredom, we won't go through every change now unless there's a specific question regarding any of those provisions. But I'll highlight the two most notable changes, the most recurring changes within the chapter. First, most of the changes are minor adjustments in wording to reflect that OAH will handle the hearing duties, where the current language is broad and covers multiple possibilities, including hearings delegated and hearings retained by the board. That broadness is removed and replaced with definitive language allocating the responsibilities to OAH, with the final decision being retained by the board. The second and other most notable change is the removal of several subchapters which revolve around hearing procedures. These subchapters are removed from this chapter because they're the same or similar to OAH's rules of procedure. And since OAH will oversee these hearings, these provisions are redundant within this chapter. However, they'll be moved to a new chapter for those hearings that are going to be retained by the board. So that the board still has procedural rules for those cases that they continue to preside over. So all of those subchapters will be removed from this chapter, placed into a new chapter that is to be created for hearings held by the board. Next slide. Is there a question?
Oh, go ahead.
If the board votes in favor of the policy committee's recommendations, the exchange will take the following 3 steps to implement those changes. And some of this is a little familiar based on what Johanna was just mentioning. Rather than this being an emergency implementation, this is one that follows the procedures and takes several months to implement. So if the board does vote in favor of the policy committee's recommendation, first, the proposed COMAR amendments will be submitted to the Administrative, Executive, and Legislative Review Committee, and they'll be published in the Maryland Register for public review and public comment before they're sent back to the board for final approval. Second, and concurrently, the board will draft a delegation letter and execute a hearing agreement, essentially a memorandum of understanding between the exchange and OAH. And finally, and also concurrently, the exchange will update their current internal policies to reflect the accepted recommendations. Next.
Yeah, Madam Secretary.
So does OAH know that you're delegating this task to them?
They do. We discussed it with them and their
Who's that?
with OAH and their principal counsel.
Okay. And do you have any sense, and they agreed to take this on?
Yes.
And do we have any sense of the number of cases that might go to them?
It is going to be, we anticipate, very minuscule. Since the inception of the exchange, we've never had to take this action.
Okay.
It has become more recent in the past 6 months. We've seen the possibility arise, although it's resolved without having to take action, on 3 occasions in the past 6 months. So we anticipate 1 or 2 a year, maybe, possibly.
And then, I mean, you described it as cumbersome and what was the other word you used, and time consuming. And because it's only 1 or 2 a year, why wouldn't you just keep it since you ultimately want to make the final decision?
So cumbersome and time consuming for the producer.
Okay.
By delegating it to the Office of Administrative Hearings, the resolution process for the producer occurs much more expeditiously rather than waiting for the board to convene to hear the action.
And I'll just add that Dr. Allen and Kathleen, Dana's not here, but they're on the policy committee. So you might have other things to share as well.
Yeah, ladies.
I would just say that, if 99% of the time, the exchange experiences an issue with the producer, they bring it to the MIA word for that expeditiously. And that's certainly been the situation. But occasionally, and sometimes.
Who is the producer, just to make sure I know who the producer is?
Insurance agent.
Oh, okay,
So they're the
Okay.
licensed insurance.
Okay.
They use the word producer.
okay, it's not a term I know. Okay. Broker, I didn't know that, okay, great.
They collapsed it,
Mhm.
from broker. But, the idea is that, most of the time, the exchange notices something, they bring it to our attention. We have a basis to act very quickly to revoke that person or take action. They are then able to remove them. Occasionally, very, very rarely, there may be a circumstance where one or more, and perhaps in colluding with each other, are taking actions that are brought to our attention. But what we find there may be visible, a very large iceberg. And so we cannot move, to act summarily, may take more time. In that circumstance, it's in the board's interest to remove them perhaps from the exchange. So that you go through a parallel process. So our sense was that it made sense for the exchange to sort of fire up that capability, but taking that as an internal action and having the board convene and act as a fact-finding body that's going to then, listen to evidence and then draft finding of fact and conclusions of law, and then go through that process was probably somewhat cumbersome. Whereas the MIA delegates things to OAH all the time, they're familiar with the rules and laws around. So that was the thinking, that it made sense to send it to them for those rares.
So that's fine, I just don't delegate work unless the people that I'm delegating the work to know that it's coming and have
Oh,
said,
yeah.
yep, we can handle it, we're good to go, so that was part of the reason for.
And expertise too.
And they have
Yeah,
the-
exactly, clearly.
And they hear other cases for the health exchange as well.
Are there other questions?
So is the number going up because we now have more producers? And we've been for a while there, we had fewer producers, and I think we've been recruiting producers, so does that increase the volume, or we just run into some that are
I wouldn't be able to. I think the circumstance is the tip of the iceberg circumstance, where that's that rare circumstance where the MIA cannot operate, not act quickly enough to meet the protected needs of the exchange. And that's going to be a rare circumstance.
And typically, we really don't run into this. I mean, it's been increasingly incredibly rare that we've had this issue, but it has come up recently, which drove this.
Other questions?
It's not the beginning of a trend or something.
Hopefully.
Yeah.
Hopefully. But it did bring up the fact that there's a policy that's kind of sitting in limbo that needs to be more concrete.
And just as a reminder, the MIA is the body that has to certify the producers in the state. And then the producers also have to be authorized to sell through the exchange. So there's two levels there. And we're constantly in communication about, are they still in good standing? Are they not in good standing? So typically we catch things that, if we've had to suspend someone for a short period of time or wanted to suspend them, typically it's been because their license has run out and they haven't renewed it. And so then it's just a really short, quick turnaround, get your license renewed, you're okay. We, again, recently came upon a situation where it's a little more in depth, and that is what revealed that we didn't have this process in place. So we wanted to make sure we got it in place.
So my second question, because we've talked before about potentially referring things to OAH. Do we have an agreement with them for other things?
Yes, they handle our appeals on second level appeals,
Including contracts?
not for contracts, just for our consumer assistance
We're
appeals.
the contracts.
Hmm?
We're contracts.
Yeah, but we talked earlier in the year that as we were having a dispute on the call center, that whether we needed to refer that dispute to OAH. Actually.
We, at this point, Sharon? come in? Thank you.
Just wanted to
clarify, so there are, the regulations regarding contracts are very similar to what these regulations look like. Meaning that the board has to meet and decide if they want to handle it or whether or not they want to delegate it. And we haven't gotten to that point yet. But what we will do is, and also, as the secretary said, we still would have to ask OAH for that specific situation. Will you handle this case? So that's something that the board could take a look at as well, if they want to do something for the contract or the procurement appeals and protest to delegate those as well. I will say that OAH is not really set up to do protest and appeals. That for most state agencies goes to the Board of Contract Appeals, but of course, because we're not under, MHB is not under that process. That's why the board is really tasked with hearing those themselves.
Other question? One last one. If we go through the process with the producer and the board, the Office of Hearings and Appeals issues a finding, we would then have to accept it formally?
Correct.
Okay, and if the producer for some reason wants to appeal to us, is there any way he or she can require or force us to have a second appeal, or think, once we've said we accept the Office of Hearings and Appeals findings, that closes it?
They still have an opportunity to appeal to the regular court system as opposed to.
Yes, outside of us. Okay, cool.
But just to clarify that last point, I thought you said that the board retains the final decision.
Correct. The board retains the final administrative decision regarding the producer's authorization,
Okay.
but any administrative decision still can
Okay.
be appealed to.
Of course. You know, just to only, just to make sure we're clear, there are exceptions that can be filed by the either party, frankly, that goes to the board, that the board must hear, either written or a hearing. But it's only limited to, you know, it's not a whole, you know, trial, or it's just very limited to what is wrong about the decision. And the board, at least a quorum of the board would have to hear that and then consider that before making the decision final.
Yes, go ahead.
So I think we're getting at the question, when the OAH gives their hearing outcome, is that binding to the board?
I'm sorry, I don't understand the question.
The hearing happens with OAH. Is that their decision binding to the exchange board or not?
No, that's their decision. Their proposed order is just a recommendation to the board. The board can overturn it. They can remand it back to OAH if they choose to, or they can accept it.
Anything else? Any other questions? Therefore, I move to approve the proposed regulation amendments to Comar 14.35.10 as presented, and authorize MHBE to submit the proposed regulations for publication in the Maryland Register and to issue a delegation letter and execute a hearing agreement with the Office of Administrative Hearings. Do I have a second? Second. Any further questions or comments? All in favor, say aye. Aye. Opposed? The ayes have it. Thank you. Venkat, Venkat and Tracy, Salesforce.
Good afternoon, Madam Chair, Vice Chair, members of the board, and everybody. I am Venkat, Chief Information Officer of the exchange, and I am joined by Tracy Campbell, Procurement Manager. Today, we are going to request the board for approval to extending our Salesforce licensing. I just want to give a very brief introduction. We presented to the board last month, just for the benefit of everybody and the chair. Salesforce is our predominant customer relationship management system. Several years back, we had a legacy product that we moved out of. And we took Salesforce. And initially we procured in a different procurement mode, and the last 3 years it's through the GSA contract that procurement manager is going to explain. And once we had the CRM system, we started integrating all of our other applications as I know here. We not only support the call center calls, which turns around 1 million tickets every year. Actually, we started back in 2017, it was around 800,000 tickets. We started somewhere in the middle of the year, and in 2018 it was 1.4 million tickets, and over the years the number of tickets reduced. Partly, I would like to believe it's because of technology in terms of revamping of the exchange in many ways and building other channels for consumers, channels like live agent chat or chatbot forum and all other additional channels that we have integrated in the system. And last year, in 2022, it was around 970,000 tickets. I think we may see some increase beyond that, predominantly due to the PHE, the public health emergency unwinding. And we also see the trend continuously reducing overall. We do see 73% of our tickets are Medicaid and around 50% QHP, in line with the enrollment trend generally, and also dental is around 1.6% and fulfillment around 9%. This is the general usage of Salesforce in terms of ticketing. However, over the years, we significantly expanded the reach of Salesforce to build various applications. As we noted, we integrated with the producer operations and also externally with our carriers and our call center, and so build several internal applications as well. It's just to give an overview of the system. We continue to use these licenses not only for the CRM system, but also to build a lot more integrated systems along tying the HBX system as well as the Salesforce system. With a brief introduction, I'll hand it over to Tracy.
Good afternoon, everyone. If you go to the next slide, Cynthia. So the procurement method that you want to explain that?
Oh, sure. This is just a comparison of licenses and costs in 2022 and 2023. We did reduce some costs compared to last year, mainly because of reducing certain licenses based on the usage. And we constantly monitor the usage of these licenses and predict our potential usage for the next fiscal year, and then adjust those license usages. As we add more and more technology, we do see some adoption across certain other areas, but we don't really see a lot of usage under the customer community logins, which we have the base number around 4,000, which is all what we need, even during a push during an open enrollment. The main license that we have, the Service Cloud, around 435 last year. Predicted next year is the license mainly for the call center and also for the technology team, which is around 15 or so. The cost is slightly less, and we would like to continue to strive around this cost. And obviously, there is always an inflationary pressure on this as well. But so far, they're able to keep it around and
Thank you. Again, good afternoon, everyone. The procurement method that we actually utilized to acquire this second renewal option was the Intergovernmental Cooperative Purchasing Agreement, which was done against GSA's contract number 35F0119Y. The renewal period is for March 2nd, 2023 through March 1st, 2024. Our approved reseller is Carasoft Technology Corporation. And as Vig had stated in the previous slide, the cost for 2022 was slightly higher, $1,167,000. And the projected cost for this year is $1,111,000. Next slide, please. This slide basically just gives a comparison from the beginning of the contract, which started in 2021 up until now, and it gives a cumulative figure of what we're gonna actually spend of $3,444,007.95. Then it basically gives a breakdown of the process that we went through. IT actually received a quote October 11th. Procurement actually prepared the 12th and sent to Carasoft on December 16th. And it closed on January the 9th, 2023. We actually presented or gave a preview at last month's board meeting of what we were going to actually present today.
Tracy, could you please explain what the torque is for those that may not know?
It's a task order request for quote.
Maybe, correct me if I'm wrong. This is a GSA contract. The GSA competed the contract at some time in the past. And companies bid and gave them a price for various kinds of activities. And then we're able to go in as a unit of local state government and purchase whatever we want at the price that was agreed upon. So we in effect buy the stuff by the yard. And so as a consequence, the competitive process occurred at the time GSA went through this, and we are simply going in and availing ourselves of that price.
That's right.
Now,
Next slide.
are there any questions for Tracy or for Venkat? Ben?
Yeah, thanks, Tracy and Venkat. So it looks like we're getting a little better deal on the sandbox, and we're getting a little better deal on Service Cloud Enterprise edition, but that may be due to reduction in the quantity. Is that correct? That
Yeah, that's
they're
correct.
not really giving us a better deal. We're getting the same deal.
Yes.
Because of the GSA contract that drives it. We're just cutting more realistically, maybe estimating what we need.
That is correct, Mr. Stephan. And one thing I would like to point out is from the data storage perspective, you can see the cost is more because we are actually asking 4 times the storage requirement for the next 2 years.
Yeah, it's just on the data. Why is it 4 times more?
So
I mean, that's the price is small in comparison. It's just 4 times more, so.
So there are a couple of reasons. One is obviously every year we are adding 1 million or so records in terms of the customer calls storing the customer calls. And also we are initiating an effort to have a fallback strategy of keeping certain data for archival purposes and moving those data into the storage area and keeping maybe a couple of years worth of data in this primary storage. That way the performance of the system can be improved. So those are the main 2 reasons.
Are there other questions? Tracy?
MHBE requests the board's approval to exercise the Intergovernmental Cooperative Purchasing Agreement, ICPA, second option year with Carasoft Technology Corporation. And award contract to Carasoft Technology Corporation in the amount of $1,111,009.89 to renew Salesforce licenses for the period March 2nd, 2023 through March 1st, 2024.
You've heard the motion. I move the motion to approve the agreement. Do I have a second? Mary Jean, are there any further questions or comments? All in favor, say aye. Aye. Opposed? The ayes have it. Thank you both.
Thank you.
So Hannah, you're back up.
Great, thank you. So I will wrap up with several policy items to talk to the board about today, all of which we're asking for board action regarding. So I'm going to start off with talking about our value plan certification standards for 2024. This is the one component of our 2024 plan certification standards that the board has not finalized yet. We can go on, and then I will just to preview talk about ask the board to vote on proposed reinsurance parameters for 2024, and then ask for approval to submit the application to CMS to extend our federal 1332 waiver under which we operate the reinsurance program. So a bunch of good meaty topics. So first up, plan certification standards. So as a reminder, the board already discussed and voted to approve plan certification standards not relating to value plan standards. And the reason that these value plan designs are coming in a second batch is because we have to make sure that we're proposing in accordance with federal actuarial value requirements dictating how generous plan benefits can be. The tool that is used to do that wasn't released until December, so we had to quickly make some updates to come to compliance with that tool. We did a second public comment period to get feedback, and now we're coming forward with our recommendations for these value plan standards for 2024. Before I get into those standards, proposed standards themselves, I'm just going to do some quick background on value plans and why we're proposing the changes we're proposing. And some of this will be just a refresher and information you've heard before. Next slide. So just as a recap, we launched value plans, as you'll probably recall, in 2020. And this was an effort, to lower out-of-pocket costs. This was sort of the reinsurance program had just launched in 2019, and it was bringing down premiums, but we were also getting consumer concerns that even though premiums were coming down, deductibles and out-of-pocket costs were still a burden. And so we launched these value plan requirements to require the carriers offer what we term value plan at each of the bronze, silver, and gold medal levels that had lower deductibles and some more favorable cost sharing design to limit out-of-pocket costs for consumers. Those have been up in place with minor tweaks since then, made year to year up to now. In 2022, we convened a stakeholder work group and affordability work group to recommend updates to the standards going forward. We felt that they've been in place for 3 or 4 years. It's time to do a refresher, look at the national landscape, and see if we think changes are appropriate. And what we asked the work group to do was to look specifically at how we could change the cost sharing design of the value plans to better support affordability, and also how we could use those plan designs to support health equity and align with statewide health population health goals. And then just as an additional piece of background, insurers on healthcare.gov and the federal marketplace are required to offer what are called standard plans, which is sort of another term for what we're proposing here starting in 2023. So we are sort of acting in accordance with the broader national landscape. So the stakeholder work group unanimously recommended updating our value plan designs to standardize cost sharing for a range of commonly used services. So this is more standardization than we had to date, where we were just setting a deductible cap and requiring that certain services be covered with co-pays pre-deductible, but we didn't say what those co-pays were. So we'll get into the details of this, but the work group recommended these updates and that carriers continue to be required to offer one of these plans at each of the bronze, silver, and gold medal levels, continue to use value plan in the plan name to identify these, and that these new requirements would replace our existing value plan standards. The policy goals that we're hoping to achieve with this additional standardization in the value plans is to improve healthcare access and affordability by guaranteeing that a number of services are available pre-deductible, prioritizing the use of co-pays, which are more predictable, versus co-insurance, where you're paying a percent of an unknown cost of care, and then promoting health equity through plan design, which we are doing with proposals to reduce cost sharing for diabetes. Another goal of further standardizing cost sharing is to better promote insurer competition, that plan designs are transparent, they're the same between carriers, and it allows consumers to not have to parse the details of, is it $50 copay better than a 10% co-insurance for the same service. Instead, those items are standardized and carriers are competing on quality and network And then also, of course, hopefully to simplify that plan shopping experience for the consumer. Now, as I said, we're only requiring one of these value plans per metal level per carrier. Carriers can continue to offer up to 3 non-value plans per metal level per carrier. So this isn't all that's available to consumers. Next. And then the guiding principles that the work group kept in mind as they were putting together the designs that I'm sharing were to promote affordability, simplicity, aligning with state health goals, equity, and then minimizing market disruption as we're transitioning from the old value plan standards to these new standards. Next slide. Last bit of background, I think, is actuarial value. So just for those who may be less familiar with this, the generosity of a health plan has to adhere to federal limits for what's called actuarial value, which is a measure of what percentage of costs on average the plan covers versus the consumer covers. So this doesn't include premium, that's in a separate bucket, but once you have the coverage, how much do you pay when you use care versus how much does your carrier pay? So for each of the metal levels, that's standardized at a percent. So for silver, generally the carrier covers about 70% of out-of-pocket costs. The individual covers about 30%. In order to determine that percentage, you have to put your plan designs through a tool the federal government creates that spits out an estimate of what that share is. Of course, these federal restrictions, the fact that we have to fit plans into these specific metal levels forces some trade-offs in cost sharing. So you can't have a plan cover everything and still be a silver plan. It can only cover 70% of costs. So as you're being more generous in one area, you may have to dial back and require the consumer to pay more for a different service. So there's a lot of trade-offs inherent in this, and it's a challenge for Maryland, and it's a challenge for all states. And states are kind of increasingly bringing this up in conversation with CMS because these trade-offs can limit what states want to achieve with their plan design. But we're kind of in the same boat as all states at the moment. So I think that's it for this slide. Next slide. So I previously shared this, I think, at the last board meeting, just to let you know that we had this information out for public comment. So we have 6 total plan designs, 1 for each metal level, but then at the silver metal level, we actually have 4 because the federal government has your different flavors of silver depending on your income. As I mentioned, if you're lower income, you can qualify for additional help with your cost sharing on silver plans. So we've got 4 flavors of silver and then a bronze and a gold plan design. When we ran the designs that the work group proposed through the new AV calculator, 3 of those designs were a little bit too generous based on the new tool. And so we had to make modifications to what the work group had proposed. The first thing we did was increase the out-of-pocket maximum on those plans. That's the cap of what an individual will pay in a year, after which the carrier covers 100% of costs. So we bumped that up by $300 to $500 depending on the plan. And that was enough to bring one of the silver plans into compliance, but not enough to fully bring the other 2 plans into compliance. So for those 2 plans, we looked at further modifications. Next slide.
Johanna,
Yes.
can you just talk, because I know Ben raised this question before, the maximum out of pocket, how often do people achieve that?
Yes, people regularly hit the maximum out of pocket. You have to really be in poor health to end up hitting that, which is why one of the reasons that it was the first thing that we adjusted. So I think it's something like less than 10, I want to say around 6% of people may on average hit their maximum out of pocket per year in the individual market. That maximum level is set by the federal government. So when we were doing the bump up, each year the federal government increases that maximum. So we bumped up to the new max for these plan designs at issue. But yes, so hopefully relatively few individuals would be impacted by this increase. So for the 2 plans where increasing the max out of pocket wasn't enough, we looked at 2 options. We worked with MHBE to kind of figure out what we thought were the 2 best ways to achieve compliance. One was to increase the specialist copay for these plans by about $10 and then increase the generic copay by $5. The other was not touch generic and just increase the specialist copay. Our recommendation when we put this out for public comment was the first option, the smaller increase in specialist copay, because that second option is a pretty big jump on the specialist copay. In addition, there's a Maryland state law that says individuals can't be required to pay more than the retail price for a generic drug. So although the copay would increase to $25, to the extent that a generic costs less than that, an individual is not going to be paying that full $25. So there's a little bit of protection there. So we put this out for public comment. We did share this with our stakeholders and the carriers. We only ended up getting feedback from the carriers. The next slide has a summary on that. And two of the carriers preferred our recommendation. One preferred United, preferred the second, but our recommendation is to go with that majority opinion and do the modest increase in specialist and generic. So you'll see that's our recommendation in the plan designs on the next slide.
So could I ask a question? Do we have any sense of specialty use? That's one, right? And then to your point about the copay, that's a lot of money if you have to see, let's say, your endocrinologist quarterly.
It is. So a couple of comments on that. I don't have that handy. That is data that's within the actual value calculator, but I can't comment on that. But if you are someone who needs more healthcare, hopefully you're not enrolling in one of these lower value plans, the bronze plan, or these less generous silver plans. You should really be in a more generous silver or gold plan if you can anticipate that you'll be needing more services, and those have much lower copays.
This goes back to the defaulting to a plan. People don't know that, so they're often picking on price based on what they think they can afford today, not understanding the impact of their healthcare utilization on their overall spend. So I've heard from lots of people, well, I have insurance, I don't know why they didn't cover it. When people have insurance, they assume it covers everything and they don't understand when copays kick in, deductibles, things like that. So is there any way, like, what does the client picking one of these plans when they're in these options, especially since only the payers responded, quite frankly, because maybe the clients didn't understand the question. But how will we help support them when they pick a plan that they didn't realize would end up being so expensive? And even if I clicked on the link in your slide 8 that talks about, you know, over $400,
Yes.
whether or not they can afford that, and what are the implications for not being able to afford a medical expense over $400.
Yeah.
So, and that will easily put them in that range with that kind of a copay.
Absolutely. Those are really good questions. I think first there's some pie charts at the very end of the appendix side. There's a pie chart if you can skip forward. Let's see, like way at the end of the deck. So in terms of how we help individuals think about more than just their premiums. Okay, this is the one I was looking for. So I'll just address this first. So this shows our distribution of enrollment by level. And so you can see that we've got about 25% of our enrollment in bronze plans or these lower value silver plans. So about 75% of our enrollees are in more generous plans where they wouldn't have these more significant copays. But in terms of how we help encourage people to think about that, we several years ago created a total cost of care tool. So as you're going through Maryland Health Connection, you have the option to say, I use low, medium, or high healthcare. And then based on that self-reported utilization and our knowledge of your age, gender, and location, we have claims data that we estimate what your total spend will be. And then we will automatically rank plans for you in the plan display from lowest total cost of care. So that should show better value plans.
So sort of along the same lines, how many people are in value-based plans today?
Roughly about 40% of our enrollment is in value plans, so they have been a popular choice.
I would just personally recommend that tool because I went through this process recently with one of my nieces, literally sat next to her, and that was incredibly helpful. To be able to go through and look at and see like her conditions, her things, et cetera, rank those places that came up. So it's really very. I think it is fast.
And the user, they know to click on the tool, or the tool pops up to say,
Yes, they
Okay.
can, they have to pass through it, they can skip it, but it's sort of their default prompt is to.
So when we got started with this, this was kind of a new concept, not completely new, but new. And, there was work being done at Michigan on value-based insurance design. Have we thought about, a more formal certification process of products that may meet sort of the VBID model? Or there's so much VBID out there right now. Medicare Advantage has a value-based insurance product. A number of specialty societies come up with their idea of a value-based insurance product. Is there more we could do in standardization? I really like the idea, of a value-based product is really what in the eyes of the beholder, and the AI tool could perhaps, with not too much longer, tell you what's the best product for you based on historic spending as well as predictive use. But for the time being, is there any way to standardize this so that everyone knows that it's not just our judgment or what a payer thinks is a good deal, but some independent assessment?
So a couple of responses to that. We did talk to the University of Michigan as we were going through the affordability work group, and we looked at their work on value-based insurance design. The challenge with that is that the low-cost plant services that they kind of recommend you increase cost sharing on or reduce coverage of are generally, there's not much actuarial value bang for the buck in that. So it's good at highlighting what you should make cheap, but there's not really much to gain from, say, reducing lower back copays on lower back imaging or something. So there's some limited utility in when you're constrained by the AV calculator. But as we were going through the work group, so I mean, yes, only the carriers commented on this specific change, but the work group was large. It was run by a navigator and a healthcare policy professor. It had advocates, navigators, the carriers, producers.
how many advocates did that on?
I can't remember.
It's one, that doesn't count. Right. So I'm just saying I mean, the payers wouldn't want 80 to 110 because then people are stopped going to their specialists. They're going to get a little alarmed by the price, right? So I'm just thinking about the people that fall in these plans and what the financial implications are with these kinds of things. I get it.
Yeah.
Just
Yes.
Maybe you can send her.
I'm happy to send the
Yeah,
first
yeah.
list. Yep. But so there were a lot of discussions and I would say kind of informal value-based insurance design discussions around, we want to keep generics low, we want to keep primary care low. Those are also in line with state goals. So it kind of came into the conversation through that lens. So this slide and the next slide present the actual cost sharing proposed, the kind of guts of these value plan designs. So you'll see that we have highlighted the changes that I mentioned to the specialist and generic copays. Overall, as you'll see, we really prioritize use of copays. There are very limited instances where coinsurance is used in these plan designs. I think that's really just on the next slide, and it's in a couple of areas like durable medical equipment where there can be quite a wide range of costs in that category. And so we didn't really, it seemed most appropriate to use a percentage rather than a set copay given the variety of equipment covered in that. We go back to the previous slide. The other thing that I'll highlight that I think I mentioned when I first discussed these is that we split out the medical and prescription deductibles and maximum out of pockets. Those are generally combined currently. By splitting them out, it's something that the work group was really in support of to help folks who may have chronic conditions that they're managing with prescriptions. They're in decent health, but they've got a lot of prescription costs. This helps limit their out-of-pocket exposure and kind of doesn't reduces disincentives to maintain compliance with their prescriptions. I think it.
Question on that, because typically you would see them combined. So how would that limit? Because, you know, to be honest, you have to go back to your provider to get your prescriptions renewed. You're not, like, nobody's going to prescribing medication for you and the night on. So I'm not sure I understand sort of that piece of the decision.
Sure, so the scenario in mind for the group, I would say, is someone who is in decent health and but is managing whatever chronic condition they have with a costly, some kind of relatively costly medication that say is costing $1,000 a month, something like that. If you had a combined prescription and medical deductible and max out of pocket, even if you don't have other medical claims, it's really just your prescription, you'd have to hit that. I think we have here medical deductible, let's say $1,000 in your gold plan, or up to $4,500 in the base silver plan. You'd have to hit that total deductible before you've satisfied it. When you have the lower drug deductible here of say just $150 in the whole plan, you're in a much better situation because you have that lower threshold to hit before the plan starts covering.
And Johanna, you might want to talk a little bit about, this is just a national issue because of the way the actuarial value calculator is determined by CMS.
Yes, of course, we would love to have, we would love to reduce cost sharing for everyone. But because of the constraints of the AV calculator, we're really, as I said, it's a lot of trade-offs, and we tried to we had extensive conversations with the work group about what to prioritize. And so in particular, we tried to keep primary care and generic costs low. We also set mental health and substance use disorder office visit costs and therapy costs, so occupational, physical, speech, and habilitative therapy, all at the same PC level, so that those services that an individual might need frequently are not cost prohibitive.
And through our national marketplace groups, we're taking this back to CMS because especially as we look at health equity and try and look at designs relating to health equity, it's a challenge.
So this, the prior slide is just, if you go back one, this is just another set of services that we have standardized cost sharing in the value plans. And then the next slide, Cynthia, is a few additional kind of footnotes. The first one, not a footnote, an important feature. From the equity standpoint, we were inspired by what DC did and really are following in their footsteps in this realm, but diabetes is a large cost burden to the state. The state has a lot of initiatives around diabetes to try to reduce the prevalence and help people with the condition control it successfully. When we were thinking about what we could do, and diabetes also has an equity component in that Black and Hispanic Marylanders are more likely to suffer from it, particularly Black Marylanders, regardless of their socioeconomic status. So the work group kind of took a bunch of information in on how we could address equity through plan design, and determined that the route they wanted to take was to minimize cost sharing for a kind of slate of standard services used by someone who's managing their diabetes in a year. So to set $0 cost sharing for those services, so that cost is not a barrier to maintaining compliance with kind of standard care protocol for someone with diabetes.
I think the critical things too, when you think about value proposition, and trying to break down barriers, that help people see the value proposition of having insurance. So value-based design, is critical. And work with the National Association of Insurance Commissioners, our special committee on race and insurance, our committee exactly parallels what Michelle was talking about with national marketing group, and also the work that Johanna and the team have been doing. So this movement towards standardization this, looking at these specific conditions and health equity. Maryland is not, it is exactly a pace, but also a bit ahead of where the rest of the nation, is. But this is the national.
All right, and I think that wraps up the slides for this portion.
Does anyone have any further questions for Johanna on this item? Then I move to approve as presented, the proposed value plan certification standards for plan year 2024 as presented. Do I have a second? Mary Jean, any further questions or comments? All in favor, say aye. Aye. Opposed? The ayes have it. Johanna.
Okay, a couple meaty topics in our remaining time. I'll try to be brief. Next slide, please. Each year, the board is required to set estimated payment parameters for the reinsurance program. This isn't the final word from the board on what these parameters will be for 2024, but carriers need something to put in their rate filings when they're submitting them to MIA. So that's something that they'll use, and then we'll gather more information back to the board in the summer with a final recommendation for what those parameters should be. But these are the parameters by which payment is determined under the reinsurance program for an individual. So there is an attachment point, co-insurance rate, and cap. So I think if we go on to the next slide, we've probably got a summary of what, just so that this is just the time I mentioned that we'll be coming back in the summer with final recommendation for the board to consider. So in terms of the parameters, the attachment point is the point at which for an individual, the reinsurance program starts covering costs for a carrier. So if an individual in 2023 has annual claims of more than $18,500, the reinsurance program will pay 80% of those costs up to $200,000. After that cap, the carrier again pays 100% of the costs. You can see that attachment point, the parameters have been pretty consistent. The board did drop the attachment point a bit in 2023. We had some higher rate increases in 2023 than we had in prior years. And so that drop in the attachment point was paired with some additional funding that had been planning to be pulled out of the program, but the insurance commissioner got that back for the program to offset the drop. And so that drop helped moderate rate increases for 2023. But so now we're considering what should we do for 2024. And our recommendation is to increase that attachment point by $1,000 to $19,500, at least for this initial pass. Next slide.
While you're doing that, I will just say that any of these changes last year is back up this year are all designed to be within that money that we fall back. So the goal is to not allow any of that to touch any of those, any of the monies that were preserved, but only use that fallback money to use in the shop.
So we looked at two scenarios for the board to give you a couple options to think about. One would be a $500 per year increase in the attachment point. The other would be $1,000. So what we modeled out was increasing that attachment point by the same amount in 2024 through 2028. The board could do a different amount each year, but for the purposes of modeling, we just assumed either 500 every year or 1,000 every year. I am happy to go into more detail on this slide, but for the sake of time, I'll just point out that the bars indicate how much funding comes into the program each year, both state in blue and green is federal. The red line shows the annual cost of the program, so you can see that increasing over time. And the purple dark colored line shows the amount of funding that we have in our state funds, and that kind of peaks in 2021 and then declines over time as the red line outpaces that bar of annual funding. So the program cost is a little bit more than what we're bringing in funding. So we're drawing down on our reserves, and you can see those reserves decline over time to the point that if, you know, based on our best projections, and these are really variable, but we do the best we can, we would have a shortfall in 2028 if we stay at the 500 attachment point. The next slide shows the $1,000 attachment point. You can see the funding situation is a little better there. And again, I'll say There are various projections in here that might change. We assume that in 2025, additional federal funding we're getting will drop. That's a current law projection. That could change. That would improve the fiscal health of the program. Also, of course, the attachment point and other parameters to be a flat $1,000 a year. Lastly, I'll mention that we're working with the MIA on a study kind of holistically to look at the reinsurance program, the parameters and how it's funded, to submit to the legislature in December and share with the board, which will have more information for the state to consider and how to shape the program in future years. The next slide shows the considerations for the board to take into account when thinking about how to change the parameters. The one that I will highlight is that increasing the attachment point does have a rate impact. So as the reinsurance program covers less claims on carriers, the carriers transfer that cost by increasing premiums. We anticipate that for 2024, each $500 increase in the attachment point will have a 0.6% impact to increase average rates. So a $1,000 increase would increase rates by about 1.2%. That's on top of however much rates would increase normally based on medical trends. So there is an impact, but our contracted actuaries do not project that that would really negatively impact. So thus we feel okay recommending that $1,000 increase in the attachment point at this. I think that's it for, oh, sorry, last thing I wanted to mention. I do want to mention that we are not just handing out dollars to the insurance companies through this program. We do also have a process of carrier accountability reporting where they submit information to us on how they're managing their costs and providing care management to try to reduce the number of people who hit the payment threshold for the reinsurance program. The next slide has some information on what is collected in those reports, but it's essentially information on cost utilization and care management. And on the next slide, we mentioned that we are targeting collecting information in particular on 4 areas: diabetes, behavioral health, asthma, and pregnancy and childbirth, which are all areas that the state is kind of has different population health goals and targets and programs. And we also collected some information on COVID. So the next slide shows what we have gathered from the carriers in terms of what they're doing in these areas for care management. In 2021, there's always a lag. So this year we'll be collecting 2 reports. None of the carriers had care management in the area of asthma or pregnancy. There were some care management programs for behavioral health and diabetes. This is in a very high level information, as you can tell. And I think we've been in kind of a baselining, kind of refining our data collection process for the last few years. And this year we are going to transition to try to take this into a more mature program and have some more detailed conversations with the carriers about these programs, what they're doing, the results, and what we do going forward.
I do want to be sensitive to the secretary's time, so.
Yes, so we can move on. There's some data here on most common conditions and most costly conditions. I won't go into detail, but I'm happy to answer questions. And then I think the next steps are just to ask the board for a motion to approve these estimates.
Does anyone have, Madam Secretary? Do you have any questions? Does anyone have any questions? Then I move to approve the estimated parameters for the 2024 state reinsurance program as presented with an attachment point of $19,500, co-insurance rate of 80%, cap of $250,000, and damping factor to be provided by the insurance commissioner. Do I have a second? Second. Let me, 2028 is a long time off, but we clearly have an unsustainable program at this point. And I hope this is the first step that we will begin to take a close look at what we might do as an alternative, because 2028 is a long way off. 2028 is not that far off. With that, does anyone else have any questions or comments? All in favor, say aye. Aye. Opposed? The ayes have it.
All right, last item is also pertaining to the reinsurance waiver. We can go on to the next slide. So The reinsurance program is operated pursuant to a waiver from the federal government. It's called a Section 1332 waiver after the portion of the ACA that authorizes these waivers. Under the waiver is the reason that we're able to get federal funding for the program. The federal government approved 1332 waivers for 5-year periods. Our first period is ending at the end of 2023. So we're required to submit an application to extend that by March 31st. The board previously approved submission to CMS in November, I believe, of a letter of intent to CMS to let them know that we would be submitting this application. And now we have the application itself before the board for to request that you authorize us to submit it. This is just a summary of what's in the application. The contents are dictated by CMS and they're pretty straightforward. We're really just at this point asking to extend the program as it currently exists. We don't anticipate any challenges with getting that approved from CMS. The program has been compliant with the requirements that CMS sets, and we anticipated that it will be going forward. Just because we're requesting this extension now and sort of a vanilla, we just want to continue what we have format, does not mean that the state can't amend the waiver in the future. So this doesn't bind us to only what is in this application. We can amend this down the road if we have other things we want to waive and other policy goals we want to achieve. But for kind of simplicity and expediency, the easiest approach is just to get the baseline approved now. The next slide, I think, so these are guardrails that the federal government requires you to comply with in the 1332 waiver. It's essentially to make sure that no one is harmed by the waiver. And so there's three specific realms of kind of demonstrating no one's harmed, and then also needs to be budget control to the federal government. We have definitely met these in the past. I think that next slide provides a little bit of additional information on how we have performed compared to other states. I won't go into that in detail, but happy to, if there are any questions. Essentially, we're doing well, we're outperforming kind of our peers. We have the most generous reinsurance program in the country, and it shows in our premium reductions and our enrollment gains. Then more detail on this, we can skip the next couple of slides. I have shown these often, but basically our premiums have come down a lot, our enrollment has grown. We anticipate that we will continue to comply with these consumer protection and budget neutrality guardrails in the next 5 years of the waiver. And in terms of timeline, we would ask the board to authorize us to submit the application today. We are still in a public comment period on the application, and that is not going to close until March 7th. So the timing isn't quite ideal, but we don't anticipate that we will get any public comment that is negative about the program. We did have a public hearing on it last week, and we didn't get any public comment on that. So our proposal would be to append any public comments we get in writing between now and the end of the comment date to the application and submit that. We can also share any of those comments with the board and then get that in by the March.
I think maybe if you get any significant.
Absolutely. Yeah.
Any questions or comments?
So if 588 were to pass the permanent residence legislation, how would you fold this into the application? Would you submit this and then submit a subsequent application? I guess I'm answering the question. Go ahead.
Yes, so we talked to the bill sponsors on the drafting to make sure that the timelines in that bill allow us to get this submitted and approved before we would then amend it with what's in that bill to provide coverage to undocumented people, so we wouldn't muddy this kind of civil process.
For that bill, would there be federal subsidy? It would have to be all state subsidies.
It's not, it is possible that there could be federal subsidy, but it's unlikely. So there would really need to be state funding.
Are there any further questions or comments? Therefore, I move to approve the submission of the 1332 reinsurance waiver extension application to the United States Department of Health and Human Services and Treasury following the end of the public comment period on March 7, 2023, as presented. Do I have a second? Seeing, thank you. Any further questions or comments? All in favor, say aye. Opposed? We're at the end of our agenda. Does anyone have any last minute comments or observations? I'll take the initiative and again, welcome the secretary and we're glad you're here. Thank you. Right.
I'm sure.
Good luck.